Hi, I'm Aaron Winnick. I'm a general and hepatobiliary surgeon at Maimonides Medical Center in Brooklyn. I am board certified in general surgery. So I went to medical school in New Jersey at UMDNJ New Jersey Medical School. After that, I did my residency in general surgery at SUNY Downstate, and then I did a fellowship in transplant surgery, in abdominal transplant surgery at the NYU. My specialty is hepatobiliary surgery, which consists of liver, bile duct, and pancreas disorders, ranging from benign diseases to tumors. I also practice general surgery regarding almost anything in the abdomen. I chose that field because when I was in medical school and then in residency, I had the opportunity to work with certain people who became great mentors to me, and I enjoyed the several aspects of those fields. One is the actual surgery themselves, which are challenging, each one in its own way. There's a certain level of difficulty for each surgery and has to be approached a little differently for each patient. My particular interest in hepatobiliary surgery relates to liver disease, hepatocellular carcinoma, related to patients that have cirrhosis and then get cancer secondary to the cirrhosis. There are different ways of treating this, and we can offer most of those ways here at Maimonides now. From a surgical standpoint, we're now able to offer surgical resection as an option, which is something that was never plausible before due to the high mortality and the higher risk of bleeding from those procedures. Some of the trends with hepatobiliary surgery relate specifically to cancer. There are certain areas of the liver where you would never operate on 20, 30 years ago, and now we're finding that we have better equipment, better techniques of imaging preoperatively, and it allows for safer resections. For patients that are not able to be resected, we have abilities to use radiofrequency ablation or microwave ablation, where we're sticking heated probes into the tumor and killing all the cells with it. And that's something that we could do in the operating room under direct visualization, and we also have the ability to do it with interventional radiology. Another modality that interventional radiology can do is a type of chemoembolization, where they're going through the hepatic artery into the tumor and killing off the blood supply while also feeding some chemotherapy agents into the tumor. So one of the things that we offer here is a weekly Tumor Board meeting where we have physicians from all different specialties coming together. We have our oncologists from the Cancer Center, radiologists, gastroenterologists, and different surgeons from different specialties, all at one meeting, reviewing the films, reviewing the pathology, reviewing the patients, and trying to figure out what the best plan of care would be for that particular patient. The benefit of that is you get different levels of expertise. You have different opinions on some of the newer modalities, some of the new clinical trials that are being offered for experimental agents regarding chemotherapy, and different opinions as to which type of surgery may benefit the patient more. When a patient comes to see me in the office, I would like to sit down with them oftentimes for an hour, sometimes more, and go over all aspects of the care. And that includes the preoperative workup, the actual surgery itself, and all the intricacies of the surgery, and then the postoperative care and what our expectations are for the patient, and more importantly for the families. Especially when you're dealing with certain types of cancer, there's a lot of strain and a lot of stress on the families themselves and on the patient. And oftentimes, not everybody is comfortable asking questions at one time. So it's something that we're taking a different approach with, and we're meeting them in the office sometimes more than once to make sure that everybody understands what this whole overwhelming process is going to entail. The best part of my job, it's a combination. One is the actual surgeries themselves. I love it. I live for it. Every day I come to work, every day I'm operating, And especially if it's a complicated case, it's something that I thrive on. The more exciting part is actually seeing the patients after the surgery, when you could tell them the good news that the cancer is out, or when you see them walking and leaving the hospital, and you see them transition from being completely immobilized and having the suffering before the surgery or immediately after the surgery, and then you see the progression where they're not suffering anymore, or in some patients where the pain is just alleviated a little and they could at least have some sort of comfort.